Hi everybody, hello. Welcome to this Insights webinar with myself and Rachel that we're running today, and thank you very much to Annie for inviting us to come along. We hope you're okay. You'll notice that your cameras and microphones have been switched off for the event. There is an opportunity to ask questions throughout. You can use the Q&A or you can use the chat to do that. We'll be running through a few slides to go through our remote monitoring program and IDS and how that all worked together over the last couple of years. It's 1 minute past 1, so I'll get started now. And so you can all see my slides there. So this is a presentation on Stronger Together, Driving Primary Care Innovation with Remote Monitoring. Again, thank you very much for joining us today. As an introduction, my name's Sarah Randall. I'm Programme Manager here at Health Innovation North East North Cumbria in our digital transformation team. I also run a programme called the Innovation Design Service and lead on that out of HI NENC. Rachel, would you like to introduce yourself?
And I'm Rachel Barham. People might have known me formally as Rachel Forbister and recognise that name. And it's really nice to meet you. I'm a digital transformation programme manager. I do focus a lot around primary care and social care, but also around regulation. So it's really nice to meet you.
Great, thanks, Rachel. So just a little bit about who we are and what we do. So we're Health Innovation North East and North Cumbria, operating across that region, but we are one of 15 health innovation networks that operate across England. So we work across our region, we support our North East North Cumbria ICB, and we support innovation, we support the development of innovation, and we support the adoption and spread of innovation across NHS and social care. We really act as that trusted intermediary between the NHS, academia and industry and connect them to experts within our organisation as well as our ecosystem partners. You may have seen this before. This is our innovation pathway, and this really underpins everything that we do here at Health Innovation North East North Cumbria. So we would work with innovations and identify where they are currently on the innovation pathway, and then that helps us make decisions as to where best to emphasize and put efforts to ensure that they fulfill everything across the innovation pathway to maximize their chances of adoption and spread into the NHS. We use this across any innovations that come to us, any SMEs, and also our programs and projects that we run where we're changing ways of working within the NHS or working with health and social care to further adopt things within their organisations. As mentioned before, I run a service called our Innovation Design Service. Just to give you a bit of an oversight into that. So our Innovation Design Service, it's run out of Health Innovation North East and North Cumbria, and it's a service that we offer to our member organisations, partners and wider networks. The Innovation Design Service, or IDS for short, it was established in July 2023, and we've been running with great success ever since. We're really pleased with how our Innovation Design Service has been utilised and the difference it's making to programmes and projects and problems within the NHS. We incorporate design thinking, tools and methodologies to look at big problems and help devise solutions to those problems. So traditionally, design sprints would take place over 5 days, going through mapping, sketching, deciding on solutions, prototyping and then testing those and learning from that testing. But we don't have the luxury of that time available in health and social care. So we take elements from design thinking and rapid discovery tools to help when we're running innovation design service sessions. We also use toolkits, and some of them there are on the left of your screen, which we would take participants through to help identify things such as strengths and weaknesses, success and what they want to achieve from a session or from a problem, or as you can see there, journey mapping, which I'll come on into further detail as that was something that we utilise quite a lot of within the remote monitoring programme. These sessions are rapid. They often take place over half a day or over a full day, and we have time-boxed exercises to avoid any creep and make sure that we get the most out of the day. We also use the double diamond thinking, so we'll start small, go out broad, think of many ideas. If we're thinking about a problem, why does that problem exist? Where does it exist? Have we really found out the root cause of that problem, or is there anything else that's having an impact on that? We'll then come to a decision about what we are actually dealing with, and then we'll go broad again, adopting that double diamond to think about solutions, really thinking about lots of ideas, getting rid of that thought process of we've tried this before and it hasn't worked, to really make sure that we consider a solution from all angles, and really that brings out innovation and brings out innovative thinking. We'll then work collaboratively to come to a decision, and then that's when the prototyping and testing come through, or the further development. Sessions are really people-focused, both in the way that they're set up, but in also the tools and methodologies that we used. So we bring the right people together to make to generate the ideas and make decisions. If somebody is working with us on an IDS project, we sit down with them, we have a look at what they're trying to achieve, and then who are the best people to have around the tables to ensure that we're going to get the most from that. The last thing you want is to come up with something from a day, come out of that and think, well, we haven't thought about this person's viewpoint. That doesn't always mean that we need to have decision makers and only decision makers in the room. We need people who are working on the ground doing the job, so that we can ensure that we're taking on their viewpoints. They will understand that the best, so they will be able to bring ideas, and it's really an opportunity for them to come forward with ideas that they may have had for a long time, or ways of improving ways of working. We've done some sessions before, and some of the best ideas have come from the healthcare assistants within GP practices of how we can adopt and change things for the better for patients. It's also great to have the decision makers in there, because we want to make sure that we're on the right track, that things are working with our strategic objectives or with system priorities. So it's by making sure that we have the right people in the room, we can do that as well. In terms of the way that we do sessions, that's people-centered too. So we look at empathy mapping, we do stakeholder maps to make sure that we understand who it is that we need to influence or work with in the system. And then we use empathy maps, and we can do that on organisations, on healthcare professionals, on particular types of people, on a person, if that is what is needed. And then we can have a look at what their needs are, what their pains are, and then we can help devise and develop solutions that are tailored to those needs. So it's really people-centered. We don't drop off at the end of a session. We use plan, do, study, act cycles to make sure that we are keeping in touch with people. The last thing we want is 18 months down the line, people saying, oh, well, we discussed that at an IDS session, but what happened with that? We want to make sure that we're keeping in touch. We want to make sure that outcomes progress. And one of the ways that we do that is through plan, do, study, act cycles, checking in with people every so often to make sure that they're getting the support they need. Do we need to do any further sessions? Or also, is there any expertise within our organisation or within our wider ecosystem that would really help them develop any innovations that come out of the sessions? Also, our innovation pathway, coming back onto that. So, you know, if we've got an idea that comes out of that, we treat it like an innovation and have a look and see where is the expertise, where are the networks that are going to benefit this idea or innovation the most, and how can we utilise our innovation pathway to help that develop and help accelerate that innovation. We work across the system, and we've worked with a number of system partners, organisations, looking at various things, including digital inclusion in maternity, looking at personas of people who are within their service, and how we can offer solutions and how we can help them become more digitally included. And we've done things with our trusts in the region, looking at working with local teams to understand what problems they're facing, and working with their wider innovation team and universities to look at any ongoing projects within academia, and also using the innovation team to help them guide and advise on how we can and what the best innovations would be to take forward. We've also worked with some early stage innovators and some early stage organisations to have a look at their value propositions. How do they want to pitch themselves to best meet the market that they're dealing with? And also some programs and projects who we work with directly at HI NENC. So we've got our CDRC on there, which is a tool that it's an innovation that's come out of ourselves, where we have templates that apply to GP records, and then we're able to produce lists of patients according to certain needs and looking at how they develop their service. We've also worked with the Skills Development Network, the secure data environment in our region, and charities as well. So since July 2023, we've held probably over about 50 IDS sessions. We've brought together 1,000 participants across those sessions, and we've helped redesign 52 digital accelerator pathways. And that brings me on to the Digital Accelerator Remote Monitoring Programme, where we utilised IDS, and it's become a big part of that model, which Rachel will go on to a bit later. But just to introduce, so the Innovation Design Service was used at the beginning of the Digital Accelerator Programme, bringing together 5 GP practices for the very first session. And what they did is they looked at what success looks like for them from remote monitoring and adopting remote monitoring tools. They looked at strengths and weaknesses that they felt were from remote monitoring, and then they also utilised IDS to look at pathways. Which pathways can they begin to think about redesigning? And we really pushed them to think about, yes, there are some quick wins, but what are the more difficult? What would you find more difficult? So that they had 2 pathways to go away with as part of the programme to look at. To redesign those pathways, they looked at empathy mapping and looked at patients and patient needs and what patients would want from remote monitoring to ensure that they took into consideration their needs and they didn't just push a pathway which they wouldn't be, which patients wouldn't engage with. And that was really important and a really useful tool for our GP practices to be able to think about, well, this is the pathway that we would go with, but actually taking into consideration the patient needs, we need to tailor it, or we need to do this. We need to maybe have face-to-face once every 6 months rather than once every 12 for some of the pathways that we worked with. And then that initial work then went into their work in the remote monitoring project. And I'll pass over to Rachel, who's going to take you through that now.
Now, just a pre-warning, I've got a touch of cold, so I might go into a coughing fit at some point. But I'm ready when you are, Sarah, for my next slide, please.
Yeah.
So it's great to hear all about the Innovation Design Service. For me as a programme manager, I think it's become an integral part of the delivery of a new programme. So if we get the ICB or NHS England approaching us to say, we would like to focus on this particular area, I always build in the IDS at the beginning of that journey, because that helps us to scope out what the challenges are, to work with people across the system, to co-produce what that might look like, and to work with them along that journey. And it really helps to set that scene. And Sarah's given a really good overview of the different types of tools and that methodology and how you can use it. So when we were approached about remote monitoring, this was all about why we're doing it. And if for those on the call today who work in primary care, you'll understand that recovery plan for primary care, the 8 AM rush, all of those challenges, and actually how did technology support practices to work in a different way. So we looked at, does it empower patients? We want to help patients care for themselves. So what self-care tools, what digital technology could they use? Things like how did they use it for things like blood pressure, monitoring that at home. It could be diabetes, it could be asthma, it could be a UTI. There's lots of different things. And what was recognised as part of that recovery plan, that home monitoring can substantially improve health outcomes and also reduce the need for those urgent and irregular appointments at the GP practice. And at the time of doing this, a couple of years ago, we were seeing in the tabloids, I can never get through to my GP practice, it's taken 3 weeks, etc. So we were trying to look at that and tackle some of those issues and see if we could create capacity in general practice around that recovery plan to really help to drive that forward. Next slide, please, Sarah.
It's on a bit of a go slow, Rachel.
It's like me today then, definitely.
Is that the right? There we go.
Yeah. So we set out asking lots of questions, and that's where we should all do as programme project managers, commissioners. If you're in a practice, you should be challenging why are we doing things and what is it we're trying to address. So what were those questions? So how do we help practices to save time? What's the benefit to a practice in doing something different? It's really hard for them to come out and do some activities to then go back in because it's just so busy constantly. What about the patients who we see day to day, the revolving door patients, and could we do something different with those that don't need to come in as often? We've got lots of digital tools. So let's look at that as a question. Is there an impact on staff? So we've got to remember in all of this journey, digital is a very small part of it. It's all about change. And do we need to train the staff? What support do they need? How do they do something different? How does it feel for them? Again, asking some of these questions through that session. One of the things we also set out to do, considering COVID, the amount of money that had been already invested in technology, was how do we do something different with what we've already got and not investing it in any more technology, because actually we'd had a lot of technology that wasn't being utilised. One of the other questions as well is around, is it clinically safe? So if we're going to ask a patient to carry out something and do something in their own home using digital technology, is that safe for them to do? And is that GP or nurse confident that that's been securely monitored and it's been assessed by a clinical safety officer? And actually, what can we use it with? Whilst we use the word remote monitoring, it's not just about remote monitoring, it's about digital technology. What can we use differently between a patient and a practice to get better outcomes? And that's what the question is we were asking in the first instance. Next slide, Sarah. We also wanted to focus on the patients because at the heart of everything we do is a patient who has to do something different, who's either waiting for an appointment. We've got elderly and frail who need longer appointments. We've got people who are transient, working in different locations, travelling. So how did we do something different? So what we wanted to understand was, were the patients keen on this, and what proportion of patients could we push to not need face-to-face? What benefits would it bring to them, but also about their carbon reduction, anxiety, saving their time. Lots of different examples given to us. Did they need any equipment, or did they already have a blood pressure machine? I stand in a doctor's surgery, just about to check in, and I hear the reception say to somebody, have you got a blood pressure machine at home? Oh yes, I've got one already. So there's common things that people already have, they're already interested in their own health. We also wanted to know, do patients who want to do more using mobile phones and the internet, but they can't because they haven't got the devices or data. So we very much wanted to look at the digital inclusion aspects of that and what could we do to support those people who maybe wanted to, but they didn't feel they had the ability to do that, and how could we do that? And we linked it to one of our other programmes around digital champions. And finally is, who are the patients who want this? How did we find them? So was that through the nurse? Did we use CDRC to research and find them? Who's got high blood pressure as an example? How do we go and find those patients and record that they are actually interested in using digital as opposed to that face-to-face, because it's better for their life circumstances? Next slide, please. So IDS helped us navigate all of those wonderful questions. This is a really busy slide and you will not be able to see the details, but you will get a copy of the slides afterwards. But this is just shown at the very start of that session. We look at what is driving people forward. So having those 5 practices in the room, they had to have somebody clinical and somebody non-clinical from back office functions attend on the day. So what was driving them forward? Why were they there on the day? But what were the challenges that they were seeing? Why did they want to do something different? Was it they were sick of seeing the same patients? Or was it they were 8 AM rush and they've got 15 people standing in the queue? Or they're getting loads of complaints about how many times the people have to ring to get an appointment? There were lots of reasons. But at the bottom, it's about what's holding them back. And you can start to see things like time, not having the headspace to do things, money, investing in staff, making sure that staff are willing to be able to change. So there was lots of things that they recognised that were kind of holding them back. But ultimately you can see that there was quite a good balance of because sometimes when you do a session like this, you can have more in the bottom section and not as many in the top. But actually, we had a really great engaged group of people who were really keen to think, well, how do we save time? How do we have less stress? How do we get better patient incomes? How do we make it easier for our staff? What NHS guidance will help us to drive that forward? And how do we share that best practice? There was loads of positive things, and the sailboat exercise is a really good tool to be able to help facilitate that and draw those things out. Next slide, please, Sarah. So after we've gone through that IDS session, Sarah also talked about kind of empathy mapping, so that persona, so we kind of understood a patient as an example, but we also asked them to go away and think about, well, what's the challenge for yourselves in a practice, and what would you like to concentrate on? So this wasn't us coming with a preconceived idea to say you have to do hypertension and you have to do this. We were co-producing what their challenges were based on their experiences and their demographics of their patient groups. Some of the things that they came up with in that phase one were contraception pill check. Why do we do it the way that we do it currently? Can we do that differently? How does technology help us to do that? It means we're seeing less people. It's easier for the a young lady to get access to the medication, haven't got to come in for an appointment. Often they need their blood pressure checked. I can pop in at Boots. I don't need to go to my GP practice and waste an appointment with a healthcare assistant. There's lots of different ways they could do that. New patient registrations. They built a template and they coded that in the background, and they saved time in doing that. And they pushed patients about 25 on average a month by using that new pathway. Hypertension comes up quite a lot, and for different reasons, different specific conditions. It might be frail elderly, it might be for routine cough points, etc. So we had a couple of different options around that, but how do we make it more efficient? And then one of the other ones around health call, and by refining an existing pathway, being able to increase that target on a monthly basis. So you can see that we had a lot of different pathways, and as the programme, I'll move on to that at some point, you'll see that lots more ideas came out. So next slide, please, Sarah. So putting my programme hat on, when we are looking at certainly a new pilots and a new concept, we want to make sure we evaluate the effectiveness of that approach and its application within general practice. So Sunderland University supported us. We commissioned them to go through that journey. So what we were looking at is, does acceleration work? So consider NHS of the old. You might get a 12-month, 18-month programme using RPIW. You've got to pull people out for 5 days to do X, Y, and Z. What we were doing, working with Sarah on the IDS, is saying we're going to pull people in for 1 day, not 5. So what's the tools that maximise that day? And we're going to accelerate their adoption over a 3-month period. It's not going to be a 12-month pilot, because we were responding to some quite big demands within that general practice land around pressures in general practice. So we wanted to find that out, but we also wanted to find out how the practices felt about it. Did it work? What were the outcomes? And also what the patients thought. So the University of Sunderland did a really great job of doing that, and they measured a fantastic kind of range of different things. But what they said is that there was a significant relationship between the work that we did, the implemented pathways, between time saving and workload. So what we understood straight away was it was the right approach, that we had practices saying, oh, this is great, we've freed up 60 appointments, we've taken time off this, and it was much better. The findings also underscored the potential of remote monitoring to enhance patient care, which was a really important thing for us as well, that we could address those challenges, making sure that we consider those patients' needs. And actually being proactive with those self-management tools was really timely, and it helped support an intervention with a healthcare provider. So we were delighted, as you can imagine, with some of those reports from Sunderland University. It also gave us that evidence background to say back to our ICB and to the other ICBs across the country, the evidence is there. If you take time out to do something different, you will gain that time back. So moving on to the next slide, please, Sarah. So we're just going to show you an example of first phase of the first 5 practices. If I was a practice and I did all of these 3, you can see, plus the BP at home, you can see actually how many appointments I start to save within my practice. So a practice used contraception pill. They used e-consult, a product they had already. They didn't even know that I'd had a template built that you could do that with until we opened up their minds to say, did you know you can do this? And on average, they saved about 50 appointments per month, which was brilliant. They also did the new patient registration checks at the same time. It was the same practice, the village practice. So about 20 to 25. So they built that in the background. So they started to save 70 appointments a month. I mean, in theory, what they would normally do with that is add it back on. But they were working in a PCN. A nurse had gone off long-term sick, and they were struggling. So they offered some of their time back to help somebody else. So I thought that was a really generous approach, but it just demonstrates that we really supported them to think differently and to drive forward some capacity opportunities. We also had a UTI pathway using AccuRx, which is a common texting platform, and they saved about 35 appointments per month. And I always remember Chris, our champion from one of the practices, explaining that, you know, the kind of case, and yes, you've got your pharmacy first, and it doesn't detract from that, but then you've got a typical lady who's working full-time in a busy city centre. It's got to take a half day to get over for an appointment, or actually they could get it to do X, Y, and Z via a pharmacist and prescribe something like that pharmacist. She was able to pop out in her lunchtime. So not only did it save appointments for the practice, but actually from a patient experience, that was so much better. And it saved, you know, carbon footprint, etc. If we want to extend some of those extra benefits as well. And the BP one at home, I've mentioned already, it really extended and reached out to a lot more people, so they were exceeding their target as a result of tweaking some things in the background. Next slide, please. My voice is still holding up, so I'm not doing too bad. So with all of these things, the beauty of working in innovation design and using that methodology is we look at what the current as-is process is. We kind of map that out and document how much time that might take. And then we introduce and implement that new pathway using the PDSA cycle to ensure that we're reviewing continuously and improving until we've got something right, and then how that looks after. And then we share that because we're a HIN network, and part of even the webinar today is all about spreading adoption. So we can see this oral contraception ones used to take 15 minutes for an appointment. That was generally always with the nurse, although they did have some GP appointments. So they changed that process to be an AccuRx text that went out. They could use an interactive kiosk, which could be in the practice, or if it was convenient for them to pop into Boots or Superdrug, they could use those devices as well. And then they would ask a couple of things. The readings reviewed outside of the appointment, and then the record was updated. And they didn't need to ask all of those information in a face-to-face, which was really positive. Next slide, please. And what we've done as a result of some of this work is we've documented. So we had the support of a lady called Kate Bryden from North East Commissioning Service, who's a change manager, and she basically supported us to document each of those processes so that this, for example, is a South Albans practice, SOP, standard operating procedure, but any practice anywhere in the country can take this SOP and implement it themselves to gain those same benefits. And that was our ambition as part of this programme, is how do we share that best practice so that we can spread that much wider across many more practices. And we ran some webinars as well to support that. And we started to see the growth of that organically as a result of some of that work. These are all available online. I'm going to share the QR code with you. And the next slide will also show you we've documented that in a flowchart process, and that's just to help with people's different learning, but break down those individual steps and help people guide through what those processes are. So we'll move on to the next slide. And we just want to share some of that key learning. So when Sarah talked about the IDS and the methodology and how we don't just leave people, what we want to do is follow them throughout their journey to find out what they're doing, how they're doing, to encourage them. But we also want to find out what the learning has been, as to make sure. When we held a face-to-face session for the first scan, and then we held online for the second and third cohorts. But we brought them together to say, well, what worked? What didn't work? If we were going to roll this out wider, what would we do differently? Some of the things they documented and told us was that taking time out, and I know we say that all the time, but if you work in general practice, you know how hectic that is, and they just often don't get that time. We have to book things 6, 7, 8 weeks in advance to know that that person's got that protected time. But once we get them there, the light bulb moments, a safe space to be able to talk and work through those things was so valuable. So that was really important. They, like ourselves, already understood that the software often is there. They've just never had a deep dive into the opportunities or attended a webinar where people have told them how to do something different. AccuRx has had a really great application within that, but also use of NHS app for elements of that. eConsult if you already have that tool, or Clinic, or one of the other online consultation tools. It's often there already. We just need to tap into that and use it. We're taking that time out to do that, obviously helps support that. They recognise that there's ways to avoid or shorten appointments rather than we've done this and this is the way we've always done it. They've stepped back and thought, actually, do we need to do this? So when the GP from one of the other practices in North Tyneside came along, and they recognised Bob, who was a lorry driver. I'm sure, Sarah, you remember that story. And seven appointments to solve Bob's problem and get medication. And the GP was like, 7 appointments? Why are we doing that? And by reviewing it, they got that down to 3 and actually did some of that remotely as well. So that was so much better for a lorry driver who was often travelling the country, who had to take leave to be able to come in for an appointment, or actually just ignored his health condition. So that was really, really positive. And patients are often supportive. I know I want to do things digitally. I don't want to ring up and sit on the phone. I'm always jumping off onto the next thing. And I'm sure our audience will be of the similar opinion. So anything that we can do easier is much better for me as an individual. But that choice is important because sometimes I might want to see that patient or that GP. So we'll move on to the next slide. As with all programmes, patient participation and engagement is really, really integral. We again commissioned an external organisations to monitor that, to understand, to carry out some questionnaires with some patients. So that was an independent review of, did those pathways work? Was it the right approach? Could we roll out that at scale? And did it fit for those patients? We wanted to understand whether you were made aware of the new pathway. They might have had a UTI before and had a different experience. They might have had a contraception appointment before, but they've had a different experience. So tell us, how did that compare? Was it good? Was it better? Was it easy to use? With the monitoring tools, great. Did I still get access to staff if I needed? So they've got that fail safe. So we asked all of those questions. We had some very positive outcomes around that. Next slide, please, Sarah. So moving on to the model. So as the programme manager, I'm very keen on bringing, so not just the right people to the IDS sessions Sarah talked about, but as a steering group and a group of professionals working together to drive change, we looked at what were the common factors, particularly with primary care, of the people and the lenses that we would need to bring together. So we've talked about Innovation Design Service, which sits out on the as an enabler for the whole of the programme. But within that core section, we've made sure we've done PPIE, made sure that we've got a commissioning lead on there, ensuring we've got programme and project management from the teams, making sure that you've got some change and benefits. So it's no point in not measuring those outcomes. Need to make sure that we do that. Also making sure that you've got clinical and non-clinical representation, because you get different perspectives. They need to work back together in their practice. That was really, really essential. We also made sure we had a practice champion who could come along and challenge, because we want that steering group to be a challenging opportunity. Why are you doing that? Actually, this hasn't worked. And then we also had a clinical safety officer, Dr. Becky Haynes, who reviewed each of those pathways before they were published. And all of those standard operating procedures have been kind of certified by that clinical safety element. We set that up as a steering group with support additionally from comms and marketing. But one of the things we did do for this particular programme is we did make small payments to the practices to make sure they protected their time to step out of practice and so they could carry out that work in the first instance as pilots, so that we could gather that evidence and really invest in those outcomes to make sure we could spread and adopt further. So that's how that model pulls together, and it has its application across other areas, but those are the key lenses and the key focus areas of what we would want to do. Next slide, please, Sarah. So I've mentioned already, we kind of worked with a number of practices. So in our second phase, we've worked with approximately another 16 practices, and we wanted them all to adopt a pathway that had already been done at phase 1. So that was about that spread and adoption and learning. Did that work? But we wanted to pick something that they wanted to focus on, and that co-production. So you can see on this screen here the number of examples of different things they wanted to focus on. So we've got travel vaccines, asthma checks, something for baby immunisations, medication reviews, MSK, blood pressure monitoring, which we've had for hypertension, diabetes. One I was interested in was proxy access. So how could you do that remotely? And each of these, or majority of them, have now got a standard operating procedure, which gives you information about how you can adopt that for yourself to make those improvements in a practice. So it's been a really great journey. We probably worked with far too many practices because we only had a short amount of time, but we've been able to document their journey and record their outcomes and be able to share those, which has been brilliant. Next slide, please, Sarah. So we always like to share a little bit about the Discovery Day, because it's not for everybody, don't get me wrong, and we have some people who think, oh no, you can't change this, or I've got to see the patient, or what about the day? But actually we got some really positive, fantastic feedback from our participants in those Discovery Days, and you can see some of these examples here. One of the things was able to network and pick people's brains, which I thought was great. Not literally picking their brains, of course, it was just a general one. There was great interaction that took place. They were able to share ideas, but they were able to visualise things, and actually by mapping that journey out, they could see very visually how they might do that differently. And I think that was a great opportunity for some of those GPs and admin people. And we always get light bulb moments, and Chris, who we would have showed a video, but obviously we've only got an hour today. But Chris would tell you he got told to come along, and he thought, oh well, it's a free lunch, I may as well go along. I'm getting a free lunch, and he didn't know really why he was there. So Sarah set the scene of what we were going to tackle, and took a little bit of work to warm him up during the day. But my goodness, by over that lunchtime and come out the other side, he was rushing to share his ideas. I'd like to do this, I want to do that. And we've had to pull him back and say, hey, just let's concentrate on a couple of things at once. Don't try and boil the ocean with the 70 pathways that you wanted to work on. Let's just start small. But because he's gained that skill set from that Discovery Day, he's continuously looking for those improvements. And that's embedded now in the way that he works. And that's some of the core things of being able to invest time coming out, is that you're getting some skills to use back. And that's been really powerful. So moving on to the next slide, please. So we've got the downloaded resources. There is a hyperlink in this, but I think we've got a QR code as well. So they're available for anybody. So if you work in practice or you're working with practices, then please share this resource link to everybody and anybody. They're free to access, and there are some explainer videos in there as well for some of the pathways. So please, these are resources for the NHS, so please get them out there, because if a practice can help and they can get 30 appointments back a month or 80 appointments back a month, that has got to be absolutely brilliant. So please, we'll just leave this screen on here at the moment, because you've got that wonderful QR code that you might want to grab your phone and check. But as I say, you will get the slides. What we also did is we set up a community of practice. So those groups came together, they shared. I used to share the sessions. I'd give them each 5 minutes to tell me, what have you done, how have you done it, what support you need from us, and how are you getting on, and are you recording your benefits. They get access to SOPs. We have run masterclasses, and we do have some of those recorded. So anybody who wants access to any additional content, please reach out. And we also developed For me, that whole programme was about that action, learn and set. It wasn't about coming for one day and doing nothing. It was about a continuous journey and measuring that success with IDS weaved throughout at the beginning, the middle and the end to really support us. So moving on to the next slide, I think that might be, so just quickly, this model has worked really well. So I would take from what you can, I highly recommend as an experienced programme manager to use elements of this type of model for an approach, particularly if you're asked to accelerate adoption quite quickly. And we have picked and lifted and shifted this over to a new programme in social care, working with care homes. We've got Scott Rennie supporting from a project management perspective, and we're working across 10 care homes in North East North Cumbria to really drive change, help them to understand what GP Connect is, but using this same approach of an action learning set. They'll have to come out for some time. We're getting them back as the halfway point next week to say how you're getting on, what are you doing, and really helping them to access more information from their GP practices to drive forward change. It's a different market. It's harder in some ways. Social care can be a little bit more challenging, but we're tenacious as a team, so we're driving that forward, and we will make sure that we get some good outcomes, and we'll share that with people as and when we have into the summer of next year when we come to a conclusion. So next slide, please. We are back to Sarah. Thank you.
Yes, thanks, Rachel. That was fantastic. Looking at the remote monitoring programme, and it's really been a fantastic opportunity to be part of that and see how it's developed and see how encouraged GP practices have been as part of that programme as well, and how it's now, gained momentum and the model has been applied across other programmes as well. It's really fantastic to see. So IDS. So why does IDS work for innovation? I mean, you've heard so much today about why it works for innovation. We really, from the starting point, we really focus on what people want to get out of a session. Quite often when we sit down and we just start to have discussions, we go off on tangents and we end up at a place that we didn't mean to start off to be. And sometimes that can be quite distracting. So we make sure that at the beginning we sit down with people and we say, what are you trying to achieve from this? And we keep in touch with them on the way, because as we know, things change within the system, but we keep in touch with people and then we really mould the session around that. We decide which toolkits that we're going to use. We decide who we're going to bring along, whether there's anybody from within our organisation who needs to be there, or any of our ecosystem who would be beneficial to involve as well. It's, as I've said before, it's people-centred. We really have people at the heart of this. We make sure that our solutions are led and designed based on people's needs. It provides a real safe space for people to explore different ideas, and it can be anonymous as well. It can be really hard for people to think that then if they put their idea forward, it can be really difficult for people if they think that is going to be critiqued, but it can be anonymous. And it's really empowering to see sometimes when somebody's idea gets chosen or selected by a process of a vote, that can be really empowering for people and really encouraging for them. And Chris, as Rachel said, was one of the standout people within all of the sessions that we've had, I would say. He sat with his arms folded at the beginning saying, I'm not sure why I'm here. And now he's a real advocate for this programme and a real advocate for the tools that we used as well. And also that integration with our innovation pathway helps in terms of IDS. It makes it really unique. Our innovation pathway, in terms of we can bring IDS in to, look at the idea development and look at how we're going to develop those ideas. And then maybe we can bring it in again later on to do some value proposition, and then look at business model canvassing. What business model would we apply and what is best for that? And then strategies for adoption and spread. So IDS really supports the innovation pathway, and the innovation pathway in turn supports IDS through that expertise. We've broken it down, and we offer IDS across various different areas. So program lifecycle development, for a number of our programs, we've brought stakeholders together, and that's been really effective to bring key stakeholders and steering groups together at the beginning of a program to say, what are we trying to achieve? How are we going to do that? Who do we need to influence? And who's going to take those actions forward? And what will the priorities be of this program? In terms of value proposition, initially that was very much for SMEs, looking at products and services and how they can be tailored to meet the needs of their customers, but it has in turn been very effective at being applied to patients and healthcare professionals, and how services and programs can be adopted and altered and offered to those people as well. Strategy development, high level strategy development. How are we going to approach this? What are the best ways to tackle this? And bringing in various different stakeholders from across our ecosystem to look at that strategy development and how that would work. Pathway redesign, which has been part of the Digital Accelerator remote monitoring program, and also problem solving for health and social care. We've got this nitty-gritty problem. What is it? How can we figure out what is actually causing that problem, and then develop solutions for that problem as well? So we hope that you've all found that useful, but we would like to open to any questions if you have them, for Rachel or I or both of us. But thank you very much for listening to our presentation today. Any questions there? Just pop them in the chat. Yep. Somebody going to come in with the question there?
So I'll just respond to Anna King's question around what products we use. So generally we used AccuRx, and eConsult was quite a common one as well to be able to use, because in the Northeast North Cumbria, majority of practices had that system, but also Clinic was used across some other practices. So they mostly were the products that we used. I'll be able to share, Anna, if you're keen, if you share me your email address, what metrics with you. We've got like a whole document that's got some metrics in, which showed the improvement in the outcomes as well. So please, obviously we've shown you some of the capacity elements of that, but we have got that broken down into time and some of that feedback from the patients as well.
Tim, are you using appreciative inquiry yet? It is something that we are exploring, particularly our director Dave is keen on us including appreciative inquiry. So we're not including it yet, but it is something that we are looking to include. How do you track, monitor and evaluate these projects and programs? Are reports and metrics shared for improvement and development?
Yes.
Rich?
Yes, so because we were commissioned by the ICB to carry out this work, we have done reports out. We've done a closure report. We've got an evaluation report around that. We did a study with Sunderland University, but we also kind of governed it by a governance structure that it includes highlight reports, not just internally at our programme board, but also externally to the ICB each month. But we also identified improvement opportunities, and we held a lessons learned session for each of the cohorts to be able to gather some of that and also feed that not only back into the ICB, but into future programmes, and to take that learning. So hopefully that answers your question.
Thank you, Tim. Thank you for your comments. Thank you, everybody. Have any further questions? Is there a plan to do further work and analyse different patient cohorts?
At this stage, there isn't, but I would suspect in the future there may be. We understand, obviously, the NHS has gone through some significant changes at the moment, both at NHS England level and ICB level, of which we're very much in tune with. So whilst this isn't a priority currently, they have taken that learning and they consider some of that when they're looking at neighbourhood health, as an example, and how we do things differently for particular cohorts. One of the things that we linked it to previously was kind of the Digital Champions programme. So how do you train up and have champions in practice who can help facilitate that kind of digital aspect, encouraging patients to uptake. And I know that NHS England looking at the outcomes from some of those types of things with patient groups and how they drive that agenda forward nationally. So you will probably find out a little bit about that in the coming months and year. I think there's an appetite to do these types of things, but for us as a health innovation network, all about that spread and adoption. So as I say, these tools are available online, and whilst we won't be evaluating that, we will look at activity against and from a Google Analytics perspective to see what hits have been. So please do continue sharing that, because that's how we adopt that work further in response to Manzo's question. Thank you.
And then good luck. Are they used only across the North East North Cumbria NHS regions, or do we have any national requirements? I guess that comes into the resources, doesn't it?
It does, yes. So whilst we were commissioned locally from NENC, and we've covered right over to Carlisle, Cumbria, up into Northumberland and the borders of Yorkshire, we have ran webinars and we've attended a couple of conference opportunities to share it wider. So we are seeing pockets of elsewhere, not just North East North Cumbria, where they're starting to use those resources to implement things on their own basis. I also think those R's roles are very important, the digital transformation leads, because if they can support the delivery of some of those tools, then everybody's on a winner, in my opinion, because there's some fantastic opportunities there. So please do use them. There's an awful lot there, and they're ready to download. So please take advantage of those free tools.
Also a positive comment about the Digital Champions programme. Thank you. Good luck.
Thank you.
And yes, you can be added to our mailing list. There is a link on our website, Health Innovation North East North Cumbria, but I will pop a link in the chat as well. I will send it out with the presentation slides if I don't find that in time. Thank you. Any further questions? I mean, please do feel free to email Rachel or I if you do have any questions. We're happy for you to do that. But thank you very much, and thank you again for your time.